I would like to have a question for you. Did you try to correlate the response to pegylated interferon with the interleukin 28B genotype? Because there are some data regarding the response to interferon in patients with CC genotype.
We didn't do it ourselves, but one center in Istanbul and one center, I think in Italy, have looked at it, and in both studies did not find a correlation with IL-28B polymorphism and treatment response to pegylated interferon. Please.
Do you have any experience in HIV, HPV, HDV co-infected patients? Because here in Romania, in our cohort, as you know, they are HBV, HIV, we have around 35%, 40% from our cohort, and out of this, 7-8% have also HDV. Do you have any recommendation for this group? Because we tried with interferon for 1 year, higher dose, and we didn't receive anything except adverse events. So do you have what to do with this, because the risk to progress is very high?
I don't have personal experience, but there is a very nice study from Vincenzo Soriano from Spain, and this is the only study in delta hepatitis where prolonged treatment with tenofovir had a beneficial effect in delta hepatitis. Now, does that mean that nucleoside analog, whether it's tenofovir or entecavir of course may not be used in HIV, but I'm also thinking in terms of monoinfection, because we know that nucleoside analog do not work in delta hepatitis. Why did they work in HIV according to that study? Two explanations. One is with prolonged treatment, you have a decreased recycling of HPV into the nucleus, which may lead to decline of cccDNA on a long term. Now, is that the case? There's one study in e-antigen negative chronic hepatitis B from Greece for 5-year nucleoside analog treatment. There was a reduction in cccDNA, which was not significant, but there was also a reduction in surface antigen levels. Now, cccDNA measurement is also difficult, but that's a possibility, and we are trying to collect data of prolonged nucleoside analog treatment use in delta monoinfection, I mean dual infection with HPV without HIV. The other explanation could be that, and there is a very nice study again from Germany, which have shown that in delta hepatitis, in HPV, HIV co-infection, those patients who had a decline of surface antigen levels were those who had an increase in CD4 counts. And it is possible that antiretroviral treatment, which leads to improvement in HIV infection, which leads to immune reconstitution, was the possible reason that we have seen the positive effect of tenofovir in delta hepatitis. But we need more data to explain which of those is correct.
But can it be also because in some patients that are co-infected with hepatitis B and D, the viral load, we know that the DNA, HBV DNA is decreasing because of the replication of the RNA of the hepatitis delta. But sometimes we find a high viral load also for hep B and a lower viral load for hep D, and sometimes there are some cases, and maybe in these cases tenofovir
HPV was dominant.
Yes. HBV was dominant, and therefore tenofovir was more effective. It could be also another explanation, because I know about that study, but we didn't.
Yes. The problem, though, is that's possible, but in the study, 12 out of 16 or so had a response. And it is unusual that in a Delta hepatitis cohort, you have so many patients who are not HDV but HBV dominant. HBV dominance is possible, but it's quite rare.
So you have two questions from public. One, what do you recommend for a patient who doesn't respond after 6 or 12 months of therapy? Do you recommend to treat again with interferon?
Okay, the question is, what is meant with no response? If I have a patient whom I treat for 12 months and HDV RNA is still positive, it doesn't mean the patient is not responding. If the patient has decreased HDV RNA by more than 2 logs, it just means that duration of 1 year is simply not enough, and we should continue treatment. I would also look at ALT, because as I said, HDV RNA measurements, everybody's cooking their own soup, it's not reliable. So if you have a patient who started with a high ALT and ALT becomes normal, it should be seen as some sort of response. And if HDV RNA is positive, I would continue treatment beyond 1 year. If HDV RNA is negative, I would still follow the patient very closely and restart pegylated interferon if HDV RNA becomes positive again.
So the second question was management of patients with hepatitis B and Delta with liver cirrhosis after 2 treatments, 1 year each treatment with interferon, and after 2 years of treatment, the patient is HBs antigen negative, HBs antibody positive, HDV antibody positive, and RNA for both negative after 2 years. And the question was, is it a cure?
That's a good question. I mean, the last part, is it a cure? I would consider it's a cure for Delta hepatitis, because in terms of, let's say this patient he's surface antigen negative, Delta RNA is negative, and he would undergo immunosuppressive treatment for cancer, whatever. In Delta hepatitis, there is one case where apparently there is a flare after immunosuppressive treatment, but the one case is not convincing. So it's not like in hepatitis B, I would say, and in that sense, a cure is, at least functional cure is the right word.
Thank you. Some questions more? So in that case, we close this session. Thank you very much again.